So I will now hand over to Belinda Badman, who's delivering today's webinar. Belinda is a senior pharmacist and critical care team leader at the Princess Alexandra Hospital based in Queensland, and she's also a member of the Critical Care Leadership Committee for Specialty Practice at SHPA. So over to you, Belinda.
Okay, thanks, Julia. Okay, so before this whole pandemic started, the Critical Care Leadership Committee were in the process of planning an introductory seminar for later in the year because it's been a while since we've had one. Clearly we've had to put that on hold, but we're quite aware of the potential increased capacity or number of ICU beds going to be rolled out if this pandemic really takes hold in Australia. So we sort of saw the need to try and provide some education around this. Unfortunately, I don't have time to provide a whole 2-day program in 1 hour. So we're going to focus on the key things that we feel that will be relevant to pharmacists who might have to step up into an ICU space. So we're going to start off specifically looking at the pulmonary side of things. Okay, so the respiratory failure, because that's what these patients are most likely going to be presenting with. We'll talk about mechanical ventilation through the actual condition itself. So COVID-19 causes a condition called ARDS, and we'll go through what that means. And then the second half of the presentation, we'll just look at some really basic ICU cares and a couple of the other topics that we normally cover in the critical care seminar will be summarised very quickly, just because, I guess, to have a little bit of a background understanding of what might be going on with these patients. So we'll start off talking about respiratory failure. So common causes of respiratory failure requiring ICU admission in a usual setting include things like infection, so viral, bacterial or fungal, asthma, pulmonary embolism, pulmonary hypertension, chest trauma, cystic fibrosis, and neurological impairments such as spinal cord injuries. Clearly, what we're concerned about in the current environment is COVID-19, and it's basically been causing widespread bilateral interstitial pneumonias. And certainly the literature coming from overseas, this is one of the key, I guess, diagnostic features. If people are presenting with these pneumonias but they've run out of tests, they're pretty much assuming it's COVID-19 that's causing them. Okay. So with respiratory failure, there are it's broadly divided into 2 types. So type 1 is where we have hypoxemia without carbon dioxide retention. So this is where we have failure to ventilate, or the oxygen's not reaching the alveoli in the lungs. So the alveoli being the smallest part of the lungs where your gas exchange takes place. So we normally see this in pneumonias. So COVID-19 fits into this type 1 picture, pulmonary edema and atelectasis. The other type of respiratory failure that we do see in ICU as well is type 2, which is where we have hypoxemia with carbon dioxide retention as well. So this means we also have a failure to perfuse. So the gas exchange between the alveoli and the capillaries are impaired. Okay, and this happens in scenarios such as asthma, COPD, chest injuries, and drugs causing respiratory depression, neuromuscular disease, those kind of situations. The reason why so many of these patients come to ICU, obviously, is because of the what we can provide for them that isn't provided in other parts of the hospital. And the main therapy that we provide clearly is mechanical ventilation. Okay, so there are 2 types of mechanical ventilation available out there. So non-invasive ventilation. So this augments spontaneous breathing by delivering a preset positive pressure via a mask. Okay, so probably hear it referred to as BiPAP. Okay, so often this will be trialled in patients prior to actually intubating to see if we can put them on BiPAP for a little while and get enough recovery of respiratory function that they don't need to be intubated. Okay, so this works by providing alveoli recruitment and retention. It reduces the work of breathing. Okay. So in a regular situation, we'll consider this in patients who are able to breathe, so generate the breath, cough and protect their airway. And it's sometimes used as a weaning tool from invasive ventilation. However, current recommendations are that it's not recommended during COVID pandemic stage due to the risk of aerosolization and healthcare worker exposure. Okay, so we've just developed some guidelines within our hospital that we may still consider it during this time for patients who are clearly COVID negative. Okay, so if we had a severe asthma or something else that presented, we might still use this. But certainly for anybody who has COVID-19, we will not be using non-invasive ventilation unless we get to the stages as they have in Italy where they just have no choice but to use whatever they've got available. Okay, so mechanical ventilation, so invasive ventilation specifically. So in normal situation, the indications is where we've got patients who are unable to protect their airway or they have an airway obstruction. So for an example, you've got an unconscious person or someone who's got an airway obstruction due to anaphylaxis. Patients who are unable to breathe spontaneously, so for example, spinal cord injuries, so high spinal injuries where they don't have the nerve control to actually generate the breath. And patients remaining hypoxic on non-invasive modalities or non-invasive modalities are contraindicated for some reason, which clearly is where COVID-19 fits in. And the goal will be for these patients to intubate them early because there's less risk of aerosolization if it's a calm, planned procedure versus, oh my God, they're going to die, if we don't get this tube down right now. So certainly the earlier people present and we can keep an eye on their respiratory deterioration, it will be the safer for medical staff who have to do these procedures. For those who aren't familiar with what a ventilator actually looks like, this is just a schematic we've pulled off the interwebs. So patients have an endotracheal tube, okay, which goes down through the mouth into the trachea. Okay, and that tube is connected to the ventilator, which is the machine, via two circuits. Okay, so there's two lots of tubing. One is the inspiratory circuit for the inhaled breath, and then the exhaled breath goes out through the other circuit. And the exhaled breath goes through a filter, okay, and we have pretty strict guidelines here in Australia as to what standard of filter these are meant to be. So this help actually, something like COVID will actually be trapped within that filter and not be exposed to the external environment in the patient's room. Okay. And there's obviously the systems interface as well as that's a computer screen where we can adjust the settings of the ventilator as well. This schematic also shows a patient with a Nasogastric Tubes because clearly these patients are not going to be eating or drinking in the normal manner whilst they're intubated, so that's kind of important to consider as well. This is just a picture of an endotracheal tube for those who haven't seen one before. So it's a rigid hard plastic tube, which as I mentioned goes down through the mouth into the trachea. So it sits just above the carina, which is the point where the trachea bifurcates into the two bronchi. So it sits just above that level. So it's really important to make sure it doesn't go into one lung only. Okay, so we want to sit just above that bifurcation. And generally once the endotracheal tube's been inserted, a chest x-ray is ordered fairly quickly afterwards just to make sure it's in the right spot. On the left-hand side of this picture, you'll notice there's a little balloon on the device there. So that balloon is deflated clearly when they're putting it down, but then it's inflated to make sure it stays in the right place. And you can see there's actual measurement markings on the tube as well. So the nursing staff will check that each shift just to make sure that the tube's not being dislodged and accidentally going to come out at all, so making sure it's in the right space. Yep. Okay, so obviously having a hard piece of plastic shoved down your throat is not going to be a pleasant experience. So unless you're highly unconscious at the time it's happening, most patients require some kind of intubation medications to actually facilitate the tube being put in. So most people, most anaesthetists, intensivists who do this use a 3-drug combination. So there's usually some kind of induction agent. Ketamine is probably the most commonly used, although our unit tends to use propofol quite a bit as well. An opioid, there's a bit of analgesia, fentanyl again being the most common, and then some kind of neuromuscular blocker to relax the patient so that they're not fighting the tube as it's going down. Again, will depend on the situation as to which drugs used. Rocuronium is probably the most common across the country, but succinylcholine is used as well, and for some reason our unit likes vecuronium just because we like to be different. But clearly they've all got different onsets of actions, so vecuronium being a lot slower onset will actually give it before we give the induction agents, whereas generally you give those first, give the induction agents first before the neuromuscular blockers. But I am sure that the team doing this will be practicing these scenarios a lot over the next couple of weeks to make sure they've got their plans down pat as to exactly how they're going to intubate these patients as quickly and as safely as possible. Okay, so as soon as the patient's intubated, of course, then we need to connect them to a ventilator because they've still got the neuromuscular blocker on board. They're not generating breath themselves. So we use a form of ventilation called positive pressure ventilation. So it's a positive pressure forcing air into the lungs and helping recruitment of the alveoli. So basically we're wanting to make sure that every little last alveoli is getting oxygen into it and that it's actually expanding to allow the gas exchange to occur. What we can adjust with the ventilator settings is the actual volume of breath that patients get. And this is calculated on patients' ideal body weight. We can adjust the actual rate of breaths they're getting. We can adjust whether it's the ventilator machine itself or the patient that is generating the breaths that are coming in. We can adjust how much pressure is left in the lungs at the end of expiration, and this is referred to as PEEP, or positive end expiratory pressure, and the amount of oxygen inspired with each breath. Okay, so if you think of normal air that we're all breathing in now, it's not 100% oxygen. So, so for patients who don't have any particular lung issues, but they're ventilated for other reasons, such as they're unconscious or whatever, 30% oxygen is sort of a normal sort of starting range. As those numbers increase, you can sort of gauge just how severe someone's respiratory failure actually is. So the actual settings that we've chosen depend on the primary disorder, but what we'll probably find, if we do get a very large cohort of these patients, is that their settings will all be really quite similar. They'll all be managed in a very standardised kind of way. Okay, so the next thing we're going to be talking about is acute respiratory distress syndrome. Okay, so this particular syndrome has been documented as sort of being the reason for ICU admission for about 2/3 of COVID-19 patients, and this is the thing we're really planning, all of our ICU resources around. So it's defined as an acute diffuse inflammatory lung injury leading to increased pulmonary vascular permeability, increased lung weight, and loss of aerated lung tissue with hypoxemia and bilateral radiographic opacities associated with increased venous admixture, increased physiological dead space, and decreased lung compliance. So that's kind of big and long and wordy. But I guess to summarise it a little bit easier, so this is a little schematic we've borrowed from Twitter, demonstrating exactly what's happening in the lungs with this SARS-CoV-2 virus causing this disease. So if we look at the very smallest unit within the lung, which is the alveolar capillary unit, which I don't know if you can see my cursor there. Okay, so this is the actual point where you've got your gas exchange taking place. So you're getting your deoxygenated blood coming from the body, okay, exchanging with the oxygen in the air, carbon dioxide's going, and then you've got your oxygenated blood returning to the heart to be pumped around the rest of the body. Okay, what happens for people who get this disease and get the severe version of it, the body starts developing some pulmonary inflammation in response to the virus. Okay, it occurs very abruptly and it affects the entire lung. This results of leakage of fluid into the interstitial space, so between the cells and the alveolar space. Okay, and you can see here the fluid between the alveoli and the capillary. And so you can imagine how that's going to really impact on gas exchange. Okay, so the previous definition we talked about, it mentioned that the fact that increased lung weight, so that increased lung weight is all fluid build-up. Just a bit more on the definition. So the onset, so it's always acute, it's an onset of 1 week or less. Chest imaging will demonstrate bilateral opacities consistent with pulmonary edema. The origin of edema is not fully explained by cardiac failure or fluid overload, and certainly in non-COVID patients we'll often do an echo to assist with diagnosis. Although I think if someone's got a positive COVID screen, we're going to be fairly obvious, I think, as to what's going to be causing the problem, unless there's other comorbidities that are known as well. And the severity of the respiratory failure can be measured by a combination. So it's a ratio between the amount of oxygen dissolved in the arterial blood divided by the amount of oxygen actually being required to maintain sort of normal oxygenation. So clearly, as that ratio decreases, your mortality increases as well. Okay, and we do routine arterial blood gases in our patients in ICU to see how we're going with ventilation and all. So it's going to be fairly clear early on as to who the most severe patients are and where we potentially, if it comes to that stage, if we have to triage patients as to who gets into the unit. Some of these kind of laboratory tests might actually be used to make some of those decisions. Okay, so what causes ARDS other than COVID-19? So it's also divided into two types. So there's direct causes such as pneumonia, aspiration and trauma, where you've got a full pulmonary contusion injury. And there's indirect causes, so sepsis, transfusions, so blood transfusions can sometimes cause ARDS as well if you get a transfusion-related acute lung injury, pancreatitis, burn injury and trauma. So the clinical hallmark of ARDS is hypoxemia. It has a mortality of up to 50%. So this is in non-COVID patients. So already we know it's going to have a fairly high mortality rate if it's causing ARDS in many patients. 6 to 12 months for full recovery in survivors. So this is not going to be a quick fix. Okay, they're out of ICU. That's it. They can go home. These guys are going to be hanging around our hospitals for quite a long time if they do actually manage to get out of ICU. And then we know that these patients do have other issues as well when they leave ICU. So things like post-traumatic stress disorder, depression, anxiety and cognitive impairment as a result of hypoxia are quite common as well. So these are things that down the track we might need to start looking at and recognising and developing plans for as well. Okay, so how do we actually manage patients who present with ARDS for any cause? So the management really is supportive. Okay, it's aimed at improving gas exchange and preventing complications whilst the underlying disease that caused the ARDS is treated. Okay, so that's where COVID-19 is going to cause some problems for us because, we don't have a clear treatment for the diseases yet. And I won't be talking about, some of the different antiviral trials and things that are happening on because that's outside of my scope of practice and also, the time we have available for us today. Okay, so the things that we will be doing that'll be standardized. So we'll have a ventilation strategy which uses low tidal volumes. So that means we're not giving every massive volumes with each breath. And the reason for that being is we don't want to, it's like blowing air into a balloon. We don't want to give too much air in that we actually cause further damage. You blow up a balloon too much and it pops. So we'll be using low tidal volumes to prevent further trauma to the lungs. We may use permissive hypercapnia to optimize this strategy. So therefore we might actually allow the patients to retain more carbon dioxide than normal. Okay, so it might mean the patient's a little bit acidotic as a result of that as well. Okay, so this will all be getting done by the intensivists in the background, clearly not something that we'll be having much to do with, but just to know that these are the kind of things they'll be considering. Okay. Now, one of the main treatments of ARDS, which is a very, very low-tech, low-cost treatment, and is being utilised incredibly widely in the current crisis, is the way we position patients. So the prone positioning, all nursing patients face down, has been demonstrated to have significant effects on improving mortality in ARDS. Okay, so it helps to improve oxygenation by taking some of the weight off the lungs. So if you think of where your lungs sit, they sit posteriorly in your thoracic cavity. So you've got your heart, which is a reasonably heavy organ sitting on top of them, the mediastinum, which is really heavy. For female patients, you've got breast tissue. For obese patients, you may have a lot of extra mass, adipose tissue there as well. So simply by rolling somebody over onto their stomach, you're taking a lot of that weight off the lungs themselves and giving them a lot more ability to expand adequately. So this is going to be one of the most common things you're going to see if you end up with an ICU full of COVID patients. You'll probably find they're all being nursed upside down. So whilst it is a low-tech kind of treatment, it isn't the easiest thing to do. So normally it takes about 6 people to roll someone from front to back to making sure that they're not going to be dislodging any of the tubes or the endotracheal tube, any lines or anything like that as you go. So your ICU might be doing sims with this at the moment with nursing and ward staff, your orderlies practicing this so they know how to do it when the time comes to actually do it properly in real life. Okay. Again, it's not something that we as pharmacists get particularly involved in, but it's good to know why they're doing these things. As I mentioned, so one of the key things is to treat the underlying condition or cause. So there's no COVID-19 treatment at present, but if bacterial co-infection is suspected, then we would use antibiotics as per usual protocols. Oops, sorry, don't know what's happened there. Let me just come back to that. Okay, so if bacterial co-infection, as per your usual protocols, I haven't seen a lot of data coming from overseas yet as to what kind of secondary infections these patients might be getting. So it really will be just normal community-acquired pneumonia or aspiration pneumonia protocols for your hospital. Now, one of the, I guess, treatments that you might not be so aware of or so familiar with from a respiratory point of view is the use of diuretics. Okay, so diuresis combined with a conservative fluid management strategy, that means not giving patients too much fluid, has been demonstrated to improve outcomes in ARDS. So if someone's got a central venous pressure of less than 4 compared to a central venous pressure of 10 to 14, it's been demonstrated to increase ventilator-free days. The strategy can only be considered for patients who are not shocked, so if they've got a really low blood pressure, we're not going to be able to diurese them further. We'll have to get the blood pressure side of things under control first. But it is recommended in that situation you might consider using inotropes for blood pressure management rather than giving lots of fluid boluses of albumin or crystalloid crystalloid fluids. Okay, so I guess if we think back to the ARDS diagram I showed you earlier, with the increased lung weight, so it's really pulmonary edema, and that's what we're trying to prevent by diuresing these patients. So these patients may be diuresed to the point where they're almost going into acute renal failure. Okay, but it is one of the best treatments we have available to us. Other things we'll be seeing a lot of used were neuromuscular blockers. Okay, so there was a big French study back in 2010 which showed early administration of neuromuscular blockers, so within 48 hours, improved 90-day survival time and time off ventilator without increasing muscle weakness. And they were aiming for a train of 4 target of 0 to 2. So a train of 4 is a particular monitor we use where you've got a couple of electrodes attached to the radial nerve. 4 electrical pulses are put through the nerve, and then the thumb will twitch if someone is not paralysed. So if you're getting 4 pulses and 4 thumb twitches, then patient is not paralysed at all. If you're getting 4 pulses with 0 twitches, then you're completely paralysed. So we're aiming sort of a 0 to 2 paralysis with these patients. Having said that, though, the trial published just last year concluded no difference, and actually the current edition of Pharmacy Grit has in the drug scan section, it's got a review of that trial by EFEMA, if anybody wants to have a quick look at that one. However, it's still widely used. So drugs used vecuronium or cisatracurium as per your local protocol, and cisatracurium is preferred in hepatic failure. The reason why we still use these, even though last year's trial perhaps didn't suggest a benefit, is that it's still going to be very beneficial to stop patients from trying to generate breaths themselves, because we're going to want the ventilator to do all of the work. So it'll be reducing patients from trying to breathe up and override the ventilator, but also from moving around, because if patients are trying to move around, they're going to require more oxygen. Okay, so if someone's already hypoxic, the last thing you want them to be doing is increasing their oxygen demand, because we're just trying to ensure we're getting absolute, as much oxygen into them and into the essential organs as we can without diverting any of that to muscle tissues or anything else. And clearly, patients who are being paralysed must be sedated at all times. There would be absolutely nothing worse than to be paralysed and aware of what's going on, but not being able to do a thing about it. Okay, so patients who are being paralysed are sedated. In this particular situation, we're aiming for a sedation score of -5, so it's the deepest level of sedation that we aim for in ICU. Normally, if we're not paralysing someone, we'd be aiming for a sedation score of sort of 0, so calm and collected, to sort of a -1, where it's sort of a light sedation. Okay, but in this situation, the deeper the sedation, the better generally. The next couple of things I'm talking about are things we would normally use for management of pulmonary hypertension. So prostacyclins. So it's unclear whether these are likely to be used in COVID-19 or not. The ANZIC's guidelines for COVID, which were released a couple of days ago, did mention that they could be considered. So whether or not any individual units do end up using these will remain to be seen, but just, I guess, to be aware of. So prostacyclins are selective pulmonary vasodilators, most commonly used in pulmonary hypertension. They help improve ventilation and perfusion mismatch. Epoprostenol and iloprost are both available in Australia, but there's more evidence for epoprostenol in ARDS. We don't use ILA in our unit, so I don't have a lot of experience in these. So if anyone's got questions about these at the end, that's where the rest of the leadership committee will hopefully be able to help. I believe iloprost is probably more commonly used because it's easier to administer, but I could be wrong on that. There's a ceiling effect to dosages. You need to have care when patients are extubated. There's no evidence of mortality benefit in ARDS, but we might be reaching the stage where we're throwing everything and trying all we can. So if you're a unit that normally uses these, you might see them used. I don't expect that units that don't currently use them will start using them because they are a little bit complex. Inhaled nitric oxide, also used for pulmonary hypertension, and this is the preferred treatment in our unit. So it's a potent vasodilator which inhibits platelet activation and inhibits smooth muscle proliferation. Also helps to improve the ventilation perfusion mismatch, the same as the prostacyclins did. It's got beneficial physiological effects, but again, little evidence of outcome benefits. The dose range is there, and at higher doses, methemoglobinemia becomes a concern, and we monitor for that. And as with the prostacyclins, it's listed in the ANZAC's guidelines as something to consider, but only time will tell whether or not we actually use it and how effective it actually is. Okay, so Ecmo is a treatment modality we have available at not all ICUs. It's quite a complex treatment modality, but it is used in really severe ARDS cases. Again, how much it will get used in COVID, I'm not certain. It's a lot more nursing intensive, so if nursing staff are really low on the ground, then it may not be contemplated. We'll just have to wait and see. But for those who aren't familiar, Ecmo stands for Extracorporeal Membranous Oxygenation. So extracorporeal basically just means you've got a circuit which takes blood out of the body and back into the body, so it's a bit like dialysis. In this situation, it goes through a filter, an oxygenator, which is this little diamond-shaped thing on the top left of the picture there. Okay, and if you can see clearly on your screen, the blood entering the oxygenator is a lot darker in colour than the blood leaving the oxygenator, so you can actually see the difference between the oxygenated and the deoxygenated blood. And then the oxygenated blood goes through the heater for warming before it returns to the patient. Okay. So with your Ecmo circuits, there's two ways these can be configured. So VV or veno to venous Ecmo, where you've got the blood coming out of the femoral vein through the oxygenator back through the femoral vein. So this is used most commonly where you've got primary respiratory failure. Okay, so we're just bypassing the lungs and doing it that way. VA ECMO, so venous arterial ECMO, so the return blood is going back into an artery, so putting it onto the arterial side of the circulation, is used where you've got a combination of respiratory and cardiac failure. Okay, I have seen a little bit of discussion on Twitter about possibly using VA ECMO for patients who develop myocarditis as a result of COVID-19, which is another one of the issues people have been having with it. I don't know if anyone has actually done it yet. There was just a little bit of a discussion going on as to whether it would be considered. So, we'll just have to wait and see. But generally you'll find, it's the major tertiary hospitals that offer ECMO. So there will be certainly capacity issues around how many patients we're able to offer this to during this pandemic situation. Just some specific pharmacological considerations for ECMO. So sedation. So, these patients can be pretty heavily sedated anyway, even prior to getting to this, but it's really important thinking that these are really quite wide bore cannula that are going into the femoral veins. And if they dislodge at all, the risk of your patient bleeding out is quite significant. So sedation to prevent dislodging of the circuits is really essential, as well as to help comply with mechanical ventilation. So whilst the ECMO machine is doing the oxygenation, patient will still be on a ventilator, just on a very lung protective sort of settings. Again, they'll be paralysed to help comply with mechanical ventilation and reduce the oxygen demand. Patients may be anticoagulated, often at a sort of a low rate. Our process here is usually just stick them on just 500 units of heparin per hour with no particular upper target range. We'll do APTTs to make sure we're not going to exceed our normal anticoagulation kind of levels, but we won't be targeting particular numbers below that. And this is just to prevent clots in the filter. Okay, obviously the more clots you get, the less oxygen exchange you get happening there as well. And the other thing that we do is we pay a lot of attention to patients' bowels in this situation, because where the cannula are inserted, there's a high risk of cross-contamination between your stools and those catheters. So we tend to put a bowel management system in with aperients such as lactulose to liquidify the stools. Okay, so we basically just have it pouring out of the patient, but to stop the circuit from becoming contaminated. Just some quick pharmacokinetic considerations of ECMO. So the volume of distribution of lipophilic drugs may increase due to binding to the circuit. Fentanyl and voriconazole are the two drugs that particularly come to mind when I think about this. But there's more and more information coming about the pharmacokinetics of particular drugs in ECMO. So if you do have any patients in it and you're not familiar, should have no trouble finding plenty of literature to help you guide you in drug dosing, but just think about it from that point of view. The volume of distribution of hydrophilic drugs may be slightly increased due to hemodilution. So just when they're initially connecting the ECMO up, clearly we can't have any air in that line, so there's going to be fluid used in the circuits initially while it's being joined up before your blood starts circulating. So there's an extra volume of fluid being given to the patient for that purpose. ECMO is also very widely used in the neonatal and infant space. So this is where we've this should be neonatal and paediatric space. It's only kind of come into the adult space since swine flu particularly. But in your neonates and infants, if you're using it, then clearly you are going to have a much increased volume of distribution, because they've only got such small circulating blood volumes, and you're going to need a lot more than usual to get them through this machine. Altered clearances are less well defined for ECMO. So about 50% of patients on ECMO end up requiring some form of renal replacement therapy as well. It's probably not the ECMO itself that's causing the renal failure, but the fact that they've been hypoxic for such an extended period of time before going on ECMO as causing issues with clearance there. And hepatic clearance is likely to be reduced as well for similar reasons. There's been a bit of discussion going around about how we treat asthma and other kind of things during this epidemic. We're trying to avoid nebulizers on our general wards because of the risk of aerosolization and spreading the virus to other patients and staff. For patients who are in ICU, we can use either metered-dose inhalers or nebs. So metered-dose inhalers, it's just a case of taking the canister out of the inhaler, which is great unless you've got a dose counter on the puffer. That makes it always challenging to take out. And it just attaches into the endotracheal circuit, and the nurse has to coordinate the puffing of the inhaler with the inspiratory breath on the circuit. We've certainly moved away from doing this in our unit. I haven't done it in many years. I don't know if anybody else is. And we tend to use these in-circuit nebulizers. Okay, so it's an ultrasonic nebulizer, again, on the inspiratory circuit for the patient. So whilst the rest of the hospital will be avoiding nebulizing medications in COVID patients, this for us is actually more of a closed system than the previous with the canister through the inspiratory circuit. So we're going to be sticking to using nebules in ICU should they be required. There's not a lot of evidence for using nebules of any sort for patients with ARDS. Okay, it's not a bronchoconstrictive condition, but if someone came in with acute asthma secondary to COVID, this is what we would be doing. Okay, so that's it, I guess, for the respiratory failure side of things specifically. What I'm going to move on to talking about now is just some of the standard basic cares that we do in ICU for all of our patients. Okay, because whilst there's not a lot for us as pharmacists to get involved in, perhaps from the ventilator and that kind of management of sedation and paralysis, the basic cares still need to be going on in the background, and that's where we can probably have our best impact for these patients. So in ICU, there was an acronym coined many, many years ago now of FAST HUGs, which helps us remember, I guess, sort of the basic cares that we should be thinking about for each patient. So we'll just go through that quickly. So FAST HUGs, so F is for feeding. Malnutrition is associated with impaired immune function, impaired ventilatory drive, weakened respiratory muscles, and prolonged ventilation time and increased mortality. Okay, so obviously we really want to make sure that we're giving our patients the best chance as possible. from a nutrition point of view. So feeds preferably enteral to commence as soon as possible after ICU, and this is across the board for all ICU patients. But greater than 50% of ICU patients are intolerant of enterally administered feeds. And the reasons for that is manyfold. So opiates, catecholamines, fluid and electrolyte management, hypoglycemia inhibits gastric emptying, prone positioning, hypoxia. So they're things we might be worried about in this particular patient group. Response to stress or pain, and then abdominal surgery, burns, trauma, sepsis, spinal head injury. So there's lots of things that cause gastric dysfunction in our patient group, but it's really important that we do try to get some feed and some nutrition into them regardless, because otherwise they're going to turn to anaerobic metabolism, catabolic metabolism, and start burning up some of their muscles and things which are going to be important down the track when it comes to rehab side of things. So to try and improve gastric absorption, we use prokinetics. So the two agents we use routinely are metoclopramide and erythromycin. So there's probably more evidence for the effectiveness of erythromycin than metoclopramide, but because of the drug interaction concerns and QT prolongation risks and things, I think most units tend to use metoclopramide first line, all the same. Standard dose is 10 milligrams 4 times a day. Erythromycin, the exact dose to use isn't particularly clear. Our unit uses 250 QID, and we use a 1 gram vial per patient per 24-hour period, and just do the 4 doses from that single vial. But that will vary depending on units and what you do for your standard practice. And using the two in combination may be more effective than either agent alone. So if there's no contraindications, and your patient's going to be at high risk of having gastric dysfunction because they are hypoxic and being prone to non-inotropes, I'd probably suggest to the medical staff to commence both of them up front. The biggest thing we will need to look at, though, is if we are trialling any of these different antiviral agents for COVID-19, just to double check your interactions with erythromycin first. Once feeds are being consistently absorbed, you can cease the prokinetics. The other thing that happens is you can get tachyphylaxis, so receptor downgrade. So if someone's been on these agents for sort of 3 days or more and they're still not absorbing their feeds, they're probably not going to start absorbing them any sooner, keeping these things going, than if you stop them. So it can be quite hard to get people to stop these things when they're but they're still not absorbing. But stopping for a day or two, letting the receptors downregulate again, and then restarting might actually be more effective than just continuing as is without a break. Okay, so A is for analgesia. Okay, so ARDS itself is not an inherently painful condition. However, the endotracheal tube and other procedures are. Okay, so opioid infusions of fentanyl or morphine are most commonly used. I know some units do use remifentanil. And generally we titrate to pain scores if the patient is conscious. Okay, I'm not going to go into any further detail on that one, but I'm sure every unit will have a protocol as to what you would normally use and manage that in your situation. S for sedation, so we've already spoken about how it's necessary to facilitate lung protective ventilation in ARDS and to ensure all patients are well sedated whilst paralysed. So the agents that we use, most common are propofol and midazolam. Okay, so propofol, if we start having to give doses significantly higher than 200 milligrams per hour, we do run the risk of propofol infusion syndrome. Okay. It's more commonly documented in paediatrics, but I know there have been adult cases in Australia as well. So just to be aware, keep an eye on your electrolytes and your CK, and if things are starting to get really crazy and your patient's been having lots of additional boluses of propofol each hour, then we might need to consider whether or not that's contributing. Midazolam, we've sort of fallen out of favour a bit because it's been associated with delirium. However, in this sort of situation where we're trying to facilitate significant ventilatory assistance, chances are patients are going to be on both propofol and midazolam. Okay, so just be expected that if your patient does survive and then moves towards extubation, they're quite likely going to be delirious. Dexmedetomidine is a newer agent. For those who are not familiar with it, so it's an alpha agonist related to clonidine. It's more centrally acting, so it does cross the blood-brain barrier. It's a reasonable sedative agent. It doesn't have as significant effect on heart rate and blood pressure as clonidine does, but it does still have some effect. So we do have to monitor those things when we're using it as well. It generally gets used more sort of in the short term around the time when you're trying to extubate patients, because one of its biggest advantages is it doesn't cause respiratory depression. So if someone is kind of waking quite agitated, we can keep it going around the time we're actually extubating them, because we don't have to worry about it. It just helps to keep them calm around that extubation period. All patients in ICU will have a Richmond agitation score documented every hour as part of their OBS, and hopefully on a daily basis are having that plan decided by the medical staff as to what are we actually aiming for. Clearly no one's aiming for a score of +2 or above, but depending on the situation, we might be looking for 0 to minus. For these ARDS patients, though, we're going to be pushing it all the way down to -5, which is unrousable. T is for thromboprophylaxis. So 10 to 80% of ICU patients not receiving prophylaxis develop DVT. And post-mortem studies have reported PE in 7 to 27% of patients who died in ICU. DVTs are associated with more ventilator days, longer ICU and hospital stays, and increased mortality. And PE in ICU has a 30% mortality rate. As with all patients, it'll be a choice of agent, depends a little bit on renal function. Consider using larger doses in large patients, and often it's used in combination with mechanical compression devices and/or stockings as per unit protocols. So we certainly use chemical prophylaxis plus stockings and compression devices. Other units might use just compression devices and no stockings. It may be during this situation, if things get really out of hand, that it'll just be okay. We don't have any scuds available, but we have stockings, or we don't have any stockings available, but we've got scuds. So it'll be a case of using what's actually available, I think. So the H in fast hugs, so when this acronym was first developed, the H stood for head of bed elevation. So nursing patients at a semi-recumbent position of 45 degrees has been demonstrated to reduce the risk of aspiration pneumonias and things. Because that's not a very medical, pharmacy relevant kind of acronym, we've kind of adjusted it to be more useful to us. So we're using the H to stand for hyper or hypoactive delirium. Okay, so delirium affects up to 80% of ICU patients. There's going to be a very high risk in ARDS patients, as our normal delirium mitigation strategies such as sedation breaks, not using benzos, having the family available to help orientate patients will not be suitable. So unfortunately, family visiting is going to be very restricted during this particular situation. So dexmedetomidine during waking and weaning may assist with delirium management. Most units will probably use psychotropic agents of some description, whether that be olanzapine or risperidone. And I'm sure you've got protocols written around those already. So if you're seeing those used in patients in ICU, it's just to try and manage patient and staff safety during the extubation period. U stands for ulcer prophylaxis. So back in 1969, when ICU was a very new specialty, Skillman reported a lethal stress ulceration syndrome in ICU patients. Stress ulcers can prolong ICU stay by 4 to 8 days and increase mortality by up to 4-fold. The incidence is probably reduced since early initiation of ventral feeds, however, it's still standard practice. Risk factors to stress ulceration are divided into major and minor risk factors. So pretty much the recommendation is that anybody with a major risk factor or more than one minor risk factor should have stress ulcer prophylaxis. So major being mechanical ventilation and coagulopathy. So during this pandemic, everyone's going to be on it. Okay. The other minor risk factors are as listed there. So the PEPTICS trial published just in January of this year compared pantoprazole, PPIs, with ranitidine to try and work out which agent we should be using for stress ulcer prophylaxis. There was no mortality difference between the groups, so there was a slight trend towards increased mortality with PPIs, particularly in some subgroups like cardiac surgery. There was more clinically important upper GI bleeding, however, in the PPI group, but no difference in C. diff infection. So as a result of this particular trial, consensus across the ICU community is that H2RBs are now the preferred agents. However, we can't actually get our hands on them at the moment, which is a bit of a pain. So Clearly we're still using pantoprazole or whatever PPI is your choice in your unit. But at some point in the future, if ranitidine becomes available again, I dare say we'll all be switching over to that. One of the big questions is how long should stress ulcer prophylaxis be continued for, and there's not a lot of hard evidence toward this. So normally we can cease when the major risk factors are reduced, or if someone has got a combination of those minor risk factors, ceasing when the majority of those have been resolved. G is for glucose control. So approximately 90% of ICU patients develop elevated blood glucose levels. And this is because they have a hypermetabolic state due to activation of counter-regulatory hormones, cytokine responses, increased hepatic glucose production, and peripheral insulin resistance. And that's compounded by things like glucose infusions, sympathomimetics, and corticosteroids. And it's a marker of illness severity and worse outcomes. And there's been some anecdotal reports coming out of Italy of really quite hard to control blood glucose levels in this patient group as well. So it's still unclear what ideal blood sugar level we should be aiming for these patients. Current treatment protocols across the board generally start insulin infusions when BSLs are about greater than 10. We're sort of aiming to keep them between 8 to 10. But again, every unit should have a glucose and insulin protocol. So if you are covering in your ICU, refer to whatever your local protocol is. And the LUCID study is currently in progress across Australia and New Zealand ICUs, trying to give us a bit more information as to what our target range should actually be. S is for stools, so early initiation of aperients along with enteral feeds is standard practice in most ICUs. The HELP ICU trial last year demonstrated no difference in constipation or diarrhea when comparing early commencement, so day 1 to 3, or later commencement, day 6 of laxatives. So I think it's really important, just to have a look at your patient. If their bowels haven't moved in 5 days, I guess the question is, do you start aperients or do you look to see if they've been absorbing their feeds? So if nothing's been absorbed, it's probably going to be a lot less of an issue than if actually, no, they've been absorbing their feeds very well, in which case you might want to start something. And we've already talked about the use of bowel management systems in particular scenarios. Okay, we've got one quick slide about sepsis and septic shock. So COVID-19 is also reported to cause septic shock in a proportion of ICU admissions as well. So septic shock is basically tissue hypoperfusion and organ dysfunction as a result of infection. So normal treatment for septic shock is early antibiotics and early source control. Again, that's challenging. Judicious fluid replacement to maintain blood pressure, and then inotropes added in for refractory hypotension. So the inotropes we'll use generally are your vasoconstrictors, so noradrenaline first and then vasopressin. So they're about just constricting your peripheral blood vessels to try and ensure that the available blood circulation is going to the essential organs. Okay, and then ongoing supportive cares as well. Some quick PK considerations. So I haven't got time to do a full PK in critical care patients kind of talk, but things to consider. So enteral absorption is going to be reduced in patients not tolerating feeds, so consider IV alternatives where available. Those patients that are septic as well as having respiratory issues may have an increased volume of distribution if they've been given fluid loading, but also the capillary leakage increases the volume of distribution as well. So making sure that we're giving adequate loading doses of antibiotics, in particular if patients are requiring antibiotics as well. Obesity is a risk factor for worse outcomes in COVID-19, so these patients will require some increase in doses due to increased volume of distribution due to the increased body mass. So as well as increase in adipose tissue, there's an associated sort of 30% in hydrophilic tissue with every, for every amount of fat that's increased as well. Renal dysfunction is commonly being reported in these patients, as we've mentioned, probably due to hypoxia. Hepatic effects are unclear, although there's a number of patients being reported to have elevated LFTs. So we're just going to have to really see what happens with these patients and keep an eye on them and dose adjust things as we need to. And for patients who require renal replacement therapy, so that's our long, slow, continuous dialysis modality in ICU, we'll have to refer to published evidence for dosing of particular agents depending on what modality of dialysis is being used. Sorry, I don't know why it's doing that every time that little warning comes up. And the last thing to talk about is self-care. Okay, so generally for medical patients in ICU, so medical being, your normal pneumonias and that kind of patients, we have a mortality rate of about 20%. Okay, COVID-19 patients is being reported as high as 60%. Okay, so it's going to be a tough time for everybody. So look out for your colleagues and yourself. Make sure you take time to eat well, exercise, spend time with your family, FaceTime your friends, whatever you need to do, to try and keep yourself, functioning well. And remember to seek help early if you're not coping, and it's okay to admit you're not okay. SHPA has been sharing the link for the Pharmacy Support Service phone line on their Facebook page the last couple of days. So, there's pharmacy-specific resources available if you do need assistance. So just some further information. So the SHPA Critical Care Interest Group, the landing page there has links to a lot of general ICU management articles. So if you want to read more about sepsis, pharmacokinetics and those sorts of things, because this was a really quick overview, you'll find some really good links there. ANZICS, which is the Australian New Zealand Intensive Care Society, have just released their first draft of their COVID-19 guidelines, and I saw that was shared to the COVID forum on SHPA yesterday, so you'll find them on there. And then Twitter as well is a great source of information coming out of there all the time. So certain people recommend following, so ANZICS, the College of Intensive Care Medicine, Chris Nixon's an intensivist down in Melbourne who started the free open access medical education movement. So he's very good at retweeting and sharing a lot of information that's coming out about this as well. And Bug Pharmacist, is based in the UK, is collecting a lot of COVID-related resources as well. So they're ones I've found particularly useful, but there's hundreds of out there. Pretty much anybody medical with a Twitter account at the moment is, tweeting and retweeting anything that's being made available as far as guidelines and protocols for managing these patients. So in conclusion, respiratory failure is one of the most common causes of admission to ICU. ARDS due to bilateral interstitial pneumonia is the primary cause of mortality in COVID-19 patients, with septic shock and also myocarditis now being recognised as well. There's no direct treatment available. Management will be supportive. Survivors are likely to require a prolonged period of rehabilitation post-ICU, and this is going to be a marathon, not a sprint, so please pace yourselves and look after yourself. And that's it. Any questions?
Thanks very much, Belinda. We do have one question that's come through so far. So if you do have any other questions, please type them into the chat box that you'll see at the bottom of your screen there. So the first question that's come through is from Camille. Thanks for all the great info so far. What about staff movements for COVID wards/ICU, i.e. going straight from home to the ward, change into scrubs and then after your shift, potentially washing or showering before leaving? Any recommendations?
Yeah, we haven't really started discussing that too much in our unit as yet. I know a lot of the nursing staff are trying to push for scrubs being available for them because they don't currently wear them in our unit. We do have staff showers, and I believe they're going to be made available to all staff who want to use them, so I think that will be certainly something I'm considering. One thing we've been discussing with our unit is because we're digital, we may end up actually just reviewing patients externally, so not actually going up to the unit at all once there's patients being managed outside of respiratory isolation rooms, just to protect ourselves, but also to limit us needing to use the PPE, which is probably going to be restricted and or limited availability as well. Anybody else from the leadership committee got any other comments on that one? Nope.
We have another question coming through, Belinda. It's great presentation, Belinda. For patients that develop sepsis secondary to COVID-19 and need antibiotics, what agents do you think most ICUs will use? Sepsis of unknown origin or sepsis secondary to pneumonia antibiotics?
Okay, well, our guidelines don't break it down like that. So our guidelines would be sepsis due to community-acquired pneumonia or hospital-acquired pneumonia. I would expect our unit will probably go a bit more towards the hospital-acquired pneumonia sort of side of things, because I would imagine, if they do get a secondary pneumonia, it'll probably be a bit further down the track when they're already in the unit, as opposed to, they're having combined COVID and bacteria on presentation. So in that case, we would start with PIP-TAZ as our first line agent. But like I say, it will just come down to your individual hospital antibiogram and what you would normally use for those sort of hospital-acquired pneumonia patients.
Thanks, Belinda. Another question that's come through from Holly. Do you have any recommendations for cytokine release syndrome?
That one I don't. We're really looking at the very tried and tested standard kind of cares. There'll be plenty of hospitals that are looking at research and doing different kind of things, but this is one that certainly I don't have any experience with. My unit's not looking at all. Don't know whether Mel or Carly are available, whether any of their units are looking at these things.
Thanks, Mel. No, we're not looking at anything like that at the moment either.
No.
No, it's Carly, same.
Does ICU also avoid ibuprofen or NSAIDs in their treatment as per the WHO recommendations? From Katie.
We don't use NSAIDs in ICU at any point in time, so there'll be no avoiding because we don't use them. Okay, because most of our patients are at such risk of developing renal failure that it's just not a common treatment for our patients at all. Oops.
And what about steroids is another question from Helena.
Yeah, steroids, actually, that's a good question. I was meant to add that to the presentation last night and I forgot. So there's been some conflicting evidence coming out as to whether like pulse methylpred may help or harm. So the ANZICS guidelines at this stage are saying that you might consider steroids in septic shock, as we would do routinely at the moment, but for ARDS without septic shock at this stage, it's not being recommended. And I guess what ANZICS is recommending is that any treatment outside of the standard cares should be done kind of as a controlled trial in a proper controlled environment, so we can actually work out what is working and what isn't working.
A question from Namita. Hi Belinda, thanks for the great presentation. Are you scoping anything to pre-pack intubation kits or help nursing/medical staff with infusion administrations?
We are scoping those things. So I'm actually meant to be at the resuscitation meeting right now. I've had to send somebody else in my place. So the intubation kits is going to be discussed there. And I know there's been a bit of discussion on the forums about that already with the Alfred, I think, having some processes in place. Yeah, so we're scoping that. I think one of the challenges within our hospital will just be trying to get consensus of what to put in those kits. So our director of ICU is a big fan of vecuronium, and even though he doesn't go to all the codes, for many years that was the only NMB we were allowed on our resus trolleys, which caused a lot of issues with registrars who weren't used to using it. So yeah, we're certainly scoping it. Pharmacists helping with fluids, yes, we're scoping that as an option as well, particularly when nursing staff get to the stage where they're having to double up. I think, having a pharmacist and one nurse infusion round every morning, just making up 24 hours worth of infusions for each bed space will definitely be something we consider.
Are there any further questions? We've got one more that's come through. Great presentation. What about the use of ACE inhibitors? Are we avoiding them for all COVID-19 patients?
I can't speak of what's happening outside the ICU situation. Within ICU, you'll find most of these patients, as soon as we start throwing propofol at them to keep them sedated, will drop their blood pressure. So we will probably just be avoiding all antihypertensives regardless, purely for, they won't need them for blood pressure at this point in time. And I can't imagine that we're going to be, intubating patients with COVID who already have severe, heart failure or those sort of things because of, I guess, maintaining the availability of therapies for those that are actually going to be most likely to recover. So yeah, so we won't be using them here. As for patients with mild cases or milder cases on the ward, I haven't been involved in discussions with that. Our medical team leader will be having those discussions with their consultants.
Any further questions? We'll just wait a moment, Belinda, in case we've got typing happening for questions.
All good.